by the GMOA Academic Subcommittee. Today, our topic of discussion is evolving trends in the diagnosis and management of breast cancer. This is a timely lecture as the month of October being the National Breast Cancer Awareness Month. And today we have with us Dr. Minoli Joseph, Consultant Cancer Surgeon from Colombo North Teaching Hospital. Dr. Joseph graduated from Faculty of Medicine, University of Colombo, with first-class honors in clinical sciences, while winning the coveted MVP medal for the best undergraduate performance in surgery. She proceeded her postgraduate in MD in surgery and received MRCP in England. While Dr. Joseph was a member of the Council of College of Surgeons, she played a pivotal role in founding the Women in Surgery Forum to promote surgery amongst young female doctors. And today, she will be discussing with us on evolving trends in the diagnosis and management of breast cancer. Over to you, madam.
Thank you, Geetika. So, as you all know, this is the month of October, Breast Cancer Awareness Month. And as doctors, I think we should update our knowledge on breast cancer diagnosis and management because it is the commonest cancer among females in Sri Lanka as well as worldwide. So in my talk today, this is the outline. So I will briefly go to the epidemiology, risk factors, diagnosis and management and how it has changed over the years. So if we take the statistics, this is around 2022 statistics we have regarding breast cancer. Every day, 15 new females will be we will be detecting breast cancer in 15 females every day. So new cancers every day. And there will be 3 deaths per day due to breast cancer. So it's an alarming figure. Actually, it's not only in Sri Lanka. In other countries, every year will increase, the incidence will rise in breast cancer. So we have to know about breast cancer as doctors, how to diagnose it early and how to manage it. So this is actually the UK data where it says every 1 in 8 females will have breast cancer during their lifetime. So it is a very alarming figure. But actually in Sri Lanka, we are a bit lucky. It's around 1 in 20 in Sri Lanka. Sri Lanka is a low incidence country for breast cancer. But still, it is the commonest and the incidence are rising. So let's see what are the risk factors for breast cancer. Being a female is the most important risk factor, main risk factor. 99% of the females, comparing breast cancer, 99% females will get it, and only 1% males will get breast cancer. So it's a female's disease. And age, when the age is increasing, the incidence are rising. And also, there's a main risk factor, which is the family history, or your personal history of having breast, ovarian, or peritoneal cancers. So if you have first degree or second degree family members, more than 1, there is a higher risk that you also can get breast cancer in your lifetime, and also ovarian cancer as well. For that, if it is coming from a germline mutation, we can check BRCA gene, BRCA1 and 2, to see what is the probability of getting breast cancer later in life. When we see the other risk factors, radiotherapy to the chest. As a child, if you get a cancer, you might get radiotherapy to the chest. So that is a main risk factor. And now recently, this obesity also has come up as a risk factor, mainly in the postmenopausal females. So postmenopausal females, if they are getting obese, that is a risk factor for breast cancer. But actually, premenstrual, if they are obese, it is a protective factor for breast cancer. There are a lot of risk factors because there are a lot of studies going on. This is the commonest cancer among females. And previous history of breast lumps and breast biopsies for atypical ductal hyperplasia, those are risk factors. And dense breast tissue, especially when you go through a mammogram, if you see dense breast tissue, that is a risk factor. Nulliparous females, again a risk factor. And if you get pregnant later in life, maybe about 40 and above, that is also again a risk factor for breast cancer. So breastfeeding, if you are not breastfeeding, again there's a slightly high chance of getting breast cancer. And menstrual history. In menstrual history, if you get your menarche early, right, around 9-10 years, and late menopause, around 55, so you have a lot of cycles in between, a lot of menstrual cycles, which is again a risk factor for breast cancer. Tall stature, that is around more than 175 centimeters. So in Sri Lanka, it's rare incidence to be more than 175 centimeters. Again, a risk factor. They think it's due to the hormonal imbalances in the body. And using HRT. So HRT was used about 20 years back very liberally among females because anyway, females like to be looking young. So after menopause, a lot of females took hormone replacement therapy, mainly estrogen progesterone combined one, and it was found that they have a higher risk of getting breast cancer. Also, alcohol and smoking. In Sri Lanka, it's rare among females, but it's also the incidence are rising. So it is again a risk factor for breast cancer. So actually, there are a lot of studies going on, and there are some studies telling that females who are doing night shifts, they have a higher risk of getting breast cancer. That is all of us in the health sector. We are doing night shifts, so and they think that during the night we should not have any light. So when we get the light, there are some hormonal changes in the body, which will have a higher risk of getting breast cancer. A lot of studies going on for breast cancer. Now, when you see the risk factors, you can see that as a female, so you can't do much to prevent breast cancer happening. So how can you reduce the risk? What are the protective factors for breast cancer? Very few. You can see risk factors. There are 2 slides. Protective factors, only there are 2. One is breastfeeding. That should be more than 1 year. So if you are breastfeeding more than 1 year, it's a protective factor. The other important thing is physical activity. So physical activity, especially postmenopausal physical activity, is found to be a protective factor for breast cancer. So very few protective factors. There are a lot of risk factors. So how can we manage this now? Most important thing is early detection. So early detection is the #1 way to beat breast cancer. Because breast cancer is from the beginning is a systemic disease. So from the beginning, these breast cancer cells will go around the body. Even though in the scans we see only there is a breast lump, there are no axillary lymph nodes, no mets. But there will be cells going into the blood circulation, and from the beginning, this cancer is a systemic disease. So, how can we find this? We will go to that in the next slide. I can show you the survival rates. This is a 5-year survival. So you can see stage 1, basically almost all the patients have lived. So early detection again comes. When it comes to stage 2, 3, and 4, you can see a drastic drop of survival. And metastatic patients, 5-year survival is around 20%. all the new state-of-art management we have. So again, I want to emphasize early detection is the mainstay for us to beat breast cancer, because if we find it in an early stage, it is curable. So breast cancer, we can cure breast cancer if we find it in an early stage. So in Sri Lanka, we don't have a breast cancer screening program. So as I think health staff, as doctors, what we can do is we can promote self-breast examination among the females. So usually what we are telling is start around 20 years, because when you start late, you don't know what is normal and what is abnormal. You have to educate the general public. You have to start it very young, around 20 years, and it won't take much time. So if a patient is already menopaused, we can say it's the first thing you should do on the first day of every month. So first day of every month, you can within 1 minute you can do this. If you are if you are doing it regularly, it won't take much time. So we can educate the general population about self-breast examination. This is for menopaused patients. For menopaused population, so for females who are having menstruation, it will be after 1 week of their menstruation. Because if it is during or just before menstruation, the breast will be tender and the females won't examine properly. That's why we are telling after 1 week of menstruation, you should do this. So how to do the self-breast examination? You need a good privacy. Inside a room, you can stand in front of a mirror and see the symmetry of the breast and see whether there is any protrusion, pulled in, dimpling, a pulled in nipple. It should be a recent onset one. So some people have retracted nipple from birth, that is normal. Recent onset inverted nipples, there is some discharge coming from the nipple, redness, and if it is a later stage, skin changes, pod orange appearance. So all these things with the inspection we can observe. This is one of my patients. You can see the right breast, there is the contour is the contour. So this is nicely curved and this is not, this is pulled in. So obviously you can see there is some problem in this patient in the right breast. So likewise, we can educate to do a self-breast examination, mainly inspection here as well as palpation. Palpation always should be done on a lying position, because while you are seated, if you palpate the breast, everyone can feel a lump. You have to stay on a lying down position. If left breast from the right hand, right breast from the left hand, and if you are examining the left breast, a pillow should be under the left scapula, because then the breast will it will be easier for you to examine the breast. So all these three methods, going up and down methodically, from outside to inside, radially up to the nipple, and circular movements, you can come up to the nipple. You have to examine all three ways for not to miss a lump. So that is the self-breast examination as well as the clinical breast examination. So as I told you, there is no proper screening program in Sri Lanka, but our screening guideline is 50 to 70 years. Every 2 years, you should get done a mammogram for breast screening. So this is actually according to the UK guidelines, but they are also now thinking to reduce the age, because a lot of younger generation, around 40s, people are getting breast cancer now. So also if you have a higher risk, the risk factors are there, you should start at a younger age. So around 45, what we tell the people now, around 45 years, you should start every 2 years. And these mammograms don't have any side effects. So doing a mammogram won't increase the breast cancer risk. It was a myth earlier. They were telling something like that, but it won't increase the breast cancer risk. So every 2 years, very safely, you can go for a screening mammogram. And after 70 years also, I'm not telling that the patients are not getting breast cancer, but it's always in the other, like in the European countries, they always think about the what you are spending also. So above 70 years, anyway, the females are not working. So the government is not giving it above 70 years. So ideally, when you are getting old, the breast cancer risk will increase. But according to the cost effectiveness only, these guidelines are made. Right. So that is about screening. Now let's see if somebody comes with a breast lump or complaint regarding the breast, what we should do. So how to diagnose a breast cancer? Triple assessment, I'm sure everybody knows what is triple assessment: clinical examination, imaging, and pathology. So we have done the examination. That's how you do examination. And also you have to examine the axilla and see when a patient comes. Then we should go to the imaging part. So imaging part, mammography, again, it is a very highly specific and sensitive test. So mammogram and ultrasound together around 99%, you can tell properly whether a female is having a breast cancer or not. So it is a very good test, and it is a non-invasive one. So very good screening tool, these mammograms and also ultrasound scan. And when a patient comes with a complaint also, these are very good tests. And sometimes my patients come and tell, doctor, I can't do these mammograms. These are so painful. So now everything is digitalized. So we have very good equipment. So about 20 years back, yes, these plates were in metal. Now it's all silicone, and it's not painful at all now. So this is not a painful investigation, and it does not have any side effects. So it's a very good investigation to do. So apart from mammogram, if the patient is coming with a breast complaint, you have to do an ultrasound scan. In ultrasound scan, mainly we see to assess the axilla, because if there are any lymph nodes, any suspicious lymph nodes, they can tell us properly. And if there is a painful area to evaluate a specific area, we can use ultrasound. So combining ultrasound and mammogram is very good. And we will, from the radiology department, we will get a report classifying, if there's a lump, classifying it according to the BIRADS staging. So BIRADS 1 up to 3, usually we are not doing anything invasive, because 98% you don't have a breast cancer. So if it is BIRADS 4 or above only, we will go for pathological assessment. So pathological assessment, we have two methods, core biopsy and a FNAC. Nowadays, for breast lumps, we don't do FNAC. So we are almost always doing core biopsies. So every hospital usually have a core biopsy facilities. And we should always go for biopsy. Why co-biopsy is important. I will come to that next. Mainly, co-biopsy is important. We can see a histological assessment. It's not cytology, as well as the immunohistochemistry is very important. Now, as I told you all earlier, the management is very different and the survival rates are better. So for that, we need immunohistochemistry before we operate. So we have to have histology as well as immunohistochemistry. FNAC also used in managing axillary lymph nodes. So if the radiologically, if they are telling it's suspicious, we can get a FNAC and see if there are malignant cells for our management of the breast cancer. So management of breast cancer, there are mainly 4 arms. Surgery is the mainstay for curative treatment. So surgery of the breast, surgery of the axilla, and then radiotherapy and to prevent the local recurrence, chemotherapy, hormonal therapy, immunotherapy for systemic control. I told you all from in the beginning, breast cancer is from the beginning is a systemic disease. So some kind of a systemic treatment, all these patients will undergo if they are diagnosed with a breast cancer. Now there is this concept, I love me. So both these patients are having breast cancer in their left breast. So this patient has undergone a radical mastectomy. I can see the ribs fairly well, has undergone a pec major excision also. This patient, also you can see the clips here, has undergone a breast cancer surgery. You can see there's a drastic difference of management. As well as now they have found there's a difference in survival also, because this patient will live more than this patient. So about actually 400 years back, only Halsted started breast cancer surgery. At that time, he thought if you remove everything, the whole breast, the pec major, pec minor muscle, lymphatics up to supraclavicular. So it's a high morbid surgery. Actually, after that surgery, females couldn't use the affected side arm. A high morbid surgery, he thought that he can cure breast cancer. That was 400 years back. But then also they found the patients will come with meds. And then only all these studies and trials came up and found that it is a systemic disease from the beginning. And however radical you do surgery, there is no survival benefit. But unfortunately, after 400 years, these days also something, removing everything, even doctors, not only the general public, even doctors think removing the whole breast will have a survival benefit. Unfortunately, no. So I will show the recent studies to you all later. So management of breast cancer. Always we discuss the patients in MDM, multidisciplinary meeting, because we are having a tailor-made management for each and every patient. Now, the breast cancer management has changed a lot. So now there is a place for neoadjuvant chemotherapy, a very well proven management plan versus primary surgery. So in some cancer patients, there is a good survival benefit for those patients if they undergo neoadjuvant chemotherapy. So about actually now these things about 20 years back, nobody gave neoadjuvant chemotherapy for operable breast cancer. But now it's all changed. This is our Sri Lankan guidelines, which were done in 2021. There are also, we say, if the breast cancer is more than 2 centimeters, so in this arm, if it is less than 2 centimeters, irrespective of immunos, you can go for breast conservation surgery. But if the tumor is more than 2 centimeters, or if you are having lymph nodes in a triple negative breast cancer or HER2 positive breast cancer. That's why doing a core biopsy is important, where you see the ER, PR, and HER2 status. So if it is a triple negative breast cancer or a HER2 positive breast cancer, giving neoadjuvant treatment if the tumor is more than 2 centimeters or if there are lymph nodes, it has a survival benefit for the patient. Now, these are the new ESMO guidelines, that's European guidelines in 2025. They have gone further. And now they are telling in T1C, that is more than 1 centimeter, if it is triple negative, more than 1 centimeter, you go for neoadjuvant chemotherapy because again, there is a survival benefit. So now we are doing less radical surgeries and we are giving more systemic treatment and we are also getting a good survival benefit. So let's see about systemic therapy. So breast cancer, from the beginning, it's a metastatic, it's a systemic disease. So how to prevent distant mets? So 40% of early breast cancer cases will develop distant mets if managed with surgery alone. So if it is a 1 centimeter lesion, and if you manage with only surgery, there's a 40% chance of getting a mets. So these systemic therapies like chemotherapy, hormonal therapy, targeted therapy will reduce the mets by 60 to 70%.
Nice.
What are the advantages of getting neoadjuvant chemotherapy rather than adjuvant chemotherapy? Because these patients will need chemotherapy. So what is the importance of giving it before surgery? When we give it before surgery, you downstage the tumor. So before sending these patients for chemotherapy, we always send to the radiology department to apply clips for these patients. So actually, we don't have the proper metal clips for breast cancer. So what we use is LT300, where we take for these laparoscopic cholecystectomy, those clips. So those clips only they will put through a biopsy needle. They will ultrasonically insert into the tumor and around the tumor. Because if there is a full response, complete pathological response also, we know where was the tumor. So what are the other advantages of neoadjuvant chemotherapy? We can guide the post-operative therapy. So whether we have to increase that or de-escalate that. So we can plan it. And if there is a complete pathological response, we know it's a very good cancer. So if there's a favorable prognosis is better. And we can try out novel therapies, biomarker development, and also we can do the genetics testing because BRCA test will take about 1 month. So we, during this neoadjuvant therapy, we know if the patient is having the high family history, you do a BRCA testing, and then we know the BRCA testing and when we can plan the surgery. So it is very important. Patients who are indicated to have neoadjuvant chemotherapy to get it and have a good survival. So that is about chemotherapy. Then we'll come to surgery. Surgery also, as I told you, it is becoming less radical. Wide local excision is the most sought after surgery nowadays. The only thing about breast conserving surgeries, you have to undergo radiotherapy. So if you undergo mastectomy, radiotherapy only sometimes you will get, not always. But here you have to undergo radiotherapy. But radiotherapy has a lot of the side effects are much less. So there won't be any issues for patients to undergo radiotherapy. This is a very good picture. So usually when I do a breast conservation surgery, I always go through this. Every breast cancer, the site, each and every site, you have a method to preserve the breast and do a oncoplastic breast surgery. So here, now, about 10 years back, they said if it is subareola, so behind posterior to the nipple, you should not go for a breast conservation since the cosmetic outcome is also bad. But now it's not like that. For every site in the breast, you have a lot of oncoplastic breast surgery methods to have a good cosmetic outcome as well as a good cure rate. So these are the patients who have undergone. This was the retroareolar breast cancer. It was here, and the patient underwent a glisotiflap, and post-op the contour is very good. And this is a round block. Again, you can see the lump was here, and this is the incision, and this was actually taken yesterday. This patient came to the clinic, so you can see hardly you can see an incision even. So those are very good they have a very good cosmetic outcome in these surgeries. So now regarding surgery also, the most important thing is wide local excision. Now they have found wide local excision is superior to mastectomy. So actually this NSABP trial in 2002, you can see mastectomy and lumpectomy with radiation, without irradiation. So the overall survival is the same. This was in 2002. So they said even mastectomy and lumpectomy, the survival is the same. But now, this is in 2014, they have found that you can see if the patient undergoes a breast conservation surgery rather than mastectomy, same size, same grade. So everything is similar. Two patients one undergo mastectomy and one undergo breast conservation surgery. So you can see the difference. There is the breast conserving patient has lived more than the mastectomy patient. So that is a very important point. Mastectomy per se doesn't have any survival benefit. Actually, breast conservation surgery is superior to mastectomy if possible. Because sometimes we get patients like this also. This was about 1 month back. All the education we give via newspapers, TV, radio, still patients come like this. So in these patients, we can't do anything. Even it is metastatic, since it is bleeding, you can see we have to go for a palliative mastectomy. So what are the other indications for mastectomy? Not all the patients can undergo breast conservation surgery. Inflammatory breast cancer, a very aggressive form, and multicentric disease. So you have in several sites, you have breast cancer. There's diffuse microcalcification everywhere in the breast, so you can't keep the breast. And if the patient has undergone radiotherapy as a child to that site, again, you can't give radiotherapy, so you can't do breast conservation surgery. And if the margins are positive in consecutively two surgeries, you can have to go for a mastectomy. Even mastectomy, now there are methods. So this is an immediate reconstruction after mastectomy with a tram flap. Next, we will come to management of axillae. So axilla, about 70% of early breast cancers are node negative. And the good thing about breast cancer is the spread. Lymphatics will spread from level 1 to level 3 in an orderly pattern. It's very rare to have a skip lesions. So sentinel lymph node biopsy is diagnostic and prognostic for breast cancer with minimum morbidity. Because if you undergo axillary lymph node dissection, there is more than 30% risk of getting lymphedema. But sentinel lymph node biopsy, it's less than 10%. The other most important thing is there is no survival benefit by undergoing the axillary clearance. So there is no therapeutic benefit. Actually, we can stage the patient properly. That is the only thing we can get by doing axillary clearance. So actually, when I was a trainee, my trainers were very proudly, they will tell, I have removed 20 lymph nodes, I have removed 30 lymph nodes in the axilla. But now, actually, we are ashamed to tell that we have removed such a lot of lymph nodes because the patient does not have benefit by removing normal, unaffected lymph nodes. So this is a sentinel lymph node. We only use methylene blue. It's proven that methylene blue is enough. You don't need the radioactive substances. So with methylene blue, we can do a sentinel lymph node biopsy. So every hospital will have methylene blue. It's a freely available, a cheap drug. So this is the clinical evidence to undergo a sentinel lymph node biopsy. So that also in 𝗦𝗨𝗕𝗦𝗖𝗥𝗜𝗕𝗘, a long time back, they compared sentinel lymph node biopsy with axillary lymph node dissection, and they found no change. So then it became a bit advanced. They compared sentinel lymph node biopsy with axillary lymph node dissection in positive micromets. So if the patient is having micromets, any amount, so you only keep one arm will be sentinel lymph nodes, one arm will be axillary lymph node biopsy. Then also they found that there is no difference in the survival. So sentinel lymph node is also it's the same survival as axillary lymph node dissection. That is for micromets. Then came for macromets. So 1 to 2 positive macromets. This is the 𝗦𝗨𝗕𝗦𝗖𝗥𝗓𝗕𝗘 trial. And also 𝗬𝗏𝒃 trial again came without any extranodal. Even with extranodal extension, you keep. If there are less than 2 macromets, the survival is the same. Now there is a new trial going on, SOUND trial, not to do even sentinel lymph node biopsy in T1N0 patients. So it's evolving because this axillary surgery has a high risk of morbidity. Here you can see a patient with a breast cancer who has undergone axillary clearance, and you can see the arm. So this is irreversible. Once you get it, it's irreversible. So again, I'm telling you the importance of identifying a breast cancer early. So if you find the breast cancer early, there are no lymph nodes in the axilla, you do a sentinel lymph node biopsy and less risk of getting a lymphedema. Because a lot of females are getting this, usually mothers, so they have to go, even though we are telling all these preventive methods, they have to go home and cook and clean and look after children and do everything. So we can tell them, but it's difficult for them to practice it. So that is why we have to find it early. So how to prevent lymphedema? Arm should be very clean. So if you're cutting the nails, someone should do it very precisely. You should not injure your fingertips, and you should stop doing rigorous and repetitive movements. So we are not asking them not to do repetitive movements. Should not lift weight from affected arm, and there should not be any cannula, blood pressure monitoring, injections should avoid. And for first 2 years, we are giving a compression sleeve to minimize getting lymphedema. Just for completeness sake, so we have spoken about surgery and chemotherapy. Other arm is radiotherapy. Radiotherapy will reduce local recurrence. All the patients who undergo breast conserving surgery should go through radiotherapy. It is also a painless procedure where it takes about 2 to 3 minutes actually to give radiotherapy. And the side effects are much less because now we have very good radiotherapy machines. So skin burning is minimum and side effects are minimum with radiotherapy. Right. So this is the last slide. Follow-up and surveillance. So how to follow up a patient with breast cancer? So these patients, if they are ER/PR positive, they will be on hormonal treatment 5 to 10 years. And if they are hormone negative only after chemotherapy, we are not giving any oral drugs. Clinical examination and ultrasound breast every 3 to 6 months for first 3 years. That's what we are recommending. After first 3 years, we will do it annually. So mammogram also annually we have to go do during the patient's lifetime. Find if there is any other because these patients are at a high risk of getting another breast cancer, especially the opposite side also. So early detection again can cure these cancers. These patients should go follow up regularly in the clinics. In summary, so breast cancer management is evolving. It's the commonest cancer among females. It's multidisciplinary management, stage-based approach. And so we can, local control we will get via surgery and radiotherapy. And surgery is getting less radical. Systemic therapy, so most of the patients, almost all the patients will get some kind of a systemic therapy to reduce the recurrence. Axilla and nodal management, again, we are doing less radical surgery if it is not involved. With neoadjuvant chemotherapy, we can do de-escalation and personalization of the cancer treatment. And follow-up care is essential for these patients. Thank you. Any questions, please?
As there doesn't seem to be any questions, I think we'll be concluding the session for now. It was a very important and an interesting lecture, and thank you very much, Madam, for that. Thank you.
There are questions about how about DCIS management. So DCIS management, DCIS is that it has not gone beyond the basement membrane. So usually DCIS, we find it in a screen detected patient. Mammographically, you find some microcalcifications and do a core biopsy. So that is also again the importance of doing a core biopsy. We can find out whether it's an invasive cancer or a ductal carcinoma in situ. If it is a ductal carcinoma in situ, we remove that part and then patient has to undergo radiotherapy. The oncologist will decide whether the patient should be on any oral drugs or not. So both maternal and paternal side with breast cancer. So you are being very lucky being a male. So I think not for you mainly, for the female family members only the main issue. So usually males we don't recommend on any screening, but if there are a lot of aunts are having this, maybe a BRCA testing, you should go to a specialist and see whether there is a place for BRCA testing for the other family members. Yeah, you can get the PowerPoint presentation. Any other questions? Can they hear me? So lobular carcinoma in situ management. So lobular carcinoma is a better carcinoma, but in situ is like, it's a very good prognosis one. So it's ductal carcinoma is the bad prognostic one. Lobular carcinoma in situ is a very good prognosis. It's a very good prognosis. So good, is there a place for prophylactic mastectomy? So prophylactic mastectomy, we are telling for patients who are having BRCA gene positive patients to get the family completed early. The females should complete, have children early, and then we will go for a prophylactic bilateral nipple sparing, so for the better cosmetic outcome, and immediate reconstruction, what we do, as well as bilateral oophorectomy also, because they have a high risk of getting ovarian cancer. So there is a place for prophylactic mastectomy if BRCA gene is positive. So how to manage prolonged lymphedema following surgery? Actually, what we do is we will refer to the vascular surgeon. So they have these special methods. They will show the patient how to do a decompression by there will be special massaging techniques the physiotherapist will show, because unfortunately, if you have a lymphedema, you can't reverse it. You can only do what you can only do is prevent it happening. So the vascular surgeons will do some kind of strapping, and so they are the ones who are doing this. But you can't do much once you are having it. The best thing is to prevent it hitting. 37 years, female patient with positive family history of breast cancer in first degree relative. So one relative is now the BRCA testing. Now they do for a lot of triple negative breast cancers because they have a drug called olaparib, where you get a survival benefit by giving it only to BRCA positive patients. So there is now doing BRCA test also there are issues. So there are genetic counselors. The patients can go and meet, and they will tell what are the advantages and disadvantages of getting these testing done. So if the first degree relative got it at 55, if it is not triple negative, then there is a rare chance of getting BRCA positive patient. But if there are a lot of first degree, at least I think should have two. Or if you think of getting one first degree or one second degree like that, do a BRCA testing if it is not triple negative. So drug or supplements, right? So a very good question. Now there's a lot of there are a lot of talks going on regarding these supplements to prevent cancer. So nothing is proven at the moment, and I don't think you all should waste money on buying supplements to prevent cancer. So it's not proven. It has not worked for all these years. And then drugs also. So now, unfortunately, there are no very well proven drugs. But tamoxifen, sometimes the oncologist will give tamoxifen. But that is also, there are side effects also. So all these drugs, there will be side effects. So you have to always see the risk benefit ratio, and also you can't tell that you will 100% prevent it. So to 100% prevent it in a BRCA positive patient, we can go for a prophylactic mastectomy. Other than that, there are no drugs or supplements to prevent breast cancer. Hope you all can hear me. Volume is muted. Use this. Yeah, you know what? Any other questions?
Thank you very much for your past participation, and we'll meet again in 2 weeks' time with the next lecture. Thank you.